before I really get into everything, I think it's also really important that I acknowledge that both the RSC and the SWP schemes are currently undergoing significant changes, and that is especially in terms of worker welfare and well-being. Next slide, please. So these next two slides are just to provide context of the growth of these schemes. Next slide, please. As you can see, for the Australian scheme, it has grown exponentially, and it brings about other risks such as increased numbers of medical injuries and potential deaths. Next slide, please. Benefiting from well-designed pastoral care policies, RSC and SWP migrants are the most protected seasonal workers in these host countries. Yet the research reveals that workers are suffering ill health and not seeking medical treatment. Much of this is due to a lack of understanding of their rights and entitlements, not only for workers themselves, but also their team leaders and pastoral care providers and employers don't necessarily understand what they're entitled to either. Both RSC and SWP employers are required to, and indeed do, provide migrants with information on health and safety regulations before starting their employment, as well as provide medical access. Now, employers are generally quick to resolve medical injuries and personal trauma. Nonetheless, migrants often do not inform them of an injury or medical condition. The fact that migrants are sometimes not willing to seek medical treatment makes it difficult to get an accurate picture of the healthcare required in these schemes. Next slide, please. Oh, you're on it. So there are real and perceived barriers to medical access. Some of the main ones are language, cultural barriers. There's a fear that, you know, if you get medical treatment, you might not get invited back again, a sense of shame, a sense of embarrassment. It's very much gendered. There are also concerns that you'll have a lack of wages, or you're going to encounter massive medical bills that you can't pay back. However, the main ones that I'm working on at the moment, and I will do some of the other ones, the main ones I'm working on at the moment, and I want to do a larger study on, is when workers actually injure themselves, and the injury isn't just a light injury, it's something that causes disabilities. So when they come into the schemes and they get these new disabilities, sorry, next slide, please. I think I might be missing one. Yeah, when they get these disabilities, then they can't go home and work. So we're getting able-bodied people coming to New Zealand and Australia and going home with injuries without compensation. Now, Australia and New Zealand pride themselves on these schemes as being fair for Pacific seasonal workers, and that they are treated like New Zealand and Australian citizens. But in reality, if they were New Zealand and Australian citizens, they would be entitled to compensation for rehabilitation, and for even if they couldn't work again, there would be some sort of compensation. This can happen. There are a couple of insurance policies that do cover concerns such as this, but the coverage is usually limited to about 6 months. So I would like to see further work on this in the future. And I had one case study where a worker had to get a metal plate put in his leg, and he was sent home for medical repatriation. However, in his home country, they could not manage this injury, which meant that for the best medical care, he would have to continue coming back to Australia and get that treatment. However, he had no insurance because he wasn't working in the scheme anymore. He had no money because he wasn't working in the scheme anymore. Therefore, there are cases like that I think need more work within these programs, amongst many. Location access to rural health is also very challenging, let alone bringing in additional migrants to share already limited infrastructure and services. Furthermore, often migrants' working hours are not aligned with clinic hours. However, there are some medical practices that have made allowances for this and do provide after-hour service for migrant workers. But even when migrants do access medical care, more often than not, they don't always follow the instructions on their follow-up care or even understand the importance of it. such as taking antibiotics or return trips to medical services for further assessments and treatments. For some migrants, it's actually the first time that they experience Western medicine, and it can be very overwhelming. And because of the privacy laws, employers or pastoral care hosts are not always in a position to even assist a migrant worker without their permission. So it does put them in a bit of a difficult space. I remember in 2007, the first time I took an RSE worker to a medical centre, it became apparent how difficult it was for them and the medical professionals to interact. I was helping fill out, the new patient registration form. Back in those days, I did not speak his language and his English was limited. So trying to ask about medical history and explain what I meant by things such as heart conditions, strokes, etc., was painstakingly difficult, let alone for the worker to try to understand the unknown medical terminologies that most medical professionals use. Additionally, misunderstandings and miscommunications are often reasons why underlying issues take place. Next slide, please. Okay, so there are a lot of major concerns. I'm not going to go through all of them. I've mentioned some of them. I jumped ahead of myself. But health and accommodation, especially when it comes to accommodation and overcrowding, that has been a real concern. Concepts of work health and safety are not necessarily known in various places in the Pacific. So that's been an issue, and also workplace warning signs. They're often in English, and that has caused problems in the workplace as well. Next slide, please. Okay, in regards to data collection, so it's reliant on employers to provide and record data to the managing bodies of the RSE and SWP governing bodies such as MB in New Zealand, and it's not DES anymore, JOA it's called now, the Department of Employment here in Australia. So they're very reliant on that. However, the problem is what is deemed as important to report is also a problem that the governing bodies have as well, because it depends on the severity of the medical treatment, whether it gets reported or not. When I was undertaking my research during COVID-19, I was trying to examine what kind of issues were happening before COVID-19 and what was happening during COVID-19 to see if there was some comparability. However, the governing bodies again had actually changed all the categories of medical treatment, so it made it difficult for comparability. So, improved data collection would assist in, initiatives for prevention measures within the programs. And the graph that is showing on the screen right now is actually an old one from 2012. It's the last time I was actually able to get any clear medical data or information from an insurance company about what workers actually claim for. And in the orange part, 38% of those claims are for claims that we actually don't know what they are. So it makes it really difficult to know how to prevent some of the issues that workers are facing. Next slide, please. The last RSE employer survey in 2019 revealed that 67% of RSE workers arrived in good health and 33% were not. However, what this data fails to capture is at what stage these issues were documented and if there was an impact from working and living conditions in New Zealand. Knowing the health of if the health of migrants improves, deteriorates, or stays the same would be really useful and would result in improved conversations with migrants around healthcare concerns. With proper reporting, documentation, awareness programs, trust and communication, I believe that some of the barriers that I mentioned earlier could be avoided and possibly assist with prevention intervention. And I personally would like to see further studies on migrant health when returning home to the Pacific, as there's only one self-reported study, and the study wasn't a self-study on medical issues. It was just a 3-question in a larger survey where migrants got to report whether their health had improved or not. In the particular study, which came out recently, it said that it had improved, but there's plenty of anecdotal evidence that that might not be quite true. Next slide, please. Okay, in regard to health insurance, it varies. However, it is compulsory that all migrants in these schemes have health insurance. More often than not, migrants do not understand their health insurance care entitlements, and other than Orbit Health Insurance in New Zealand, I am not aware of any other insurance policies that have been translated for very specific island migrants. But even when translated, not everything is easily communicated. Even for myself, when it's in English, I struggle to look at insurance policies, to be honest. Furthermore, migrants do not have the option to shop around for the best deal of insurance providers. They're very reliant on their employers to initiate the process and do the right thing by them. The New Zealand RSE scheme has had one main insurance company, Orbit Health, that is tailored for the demands of the scheme. In New Zealand, there have been others that have entered the market, but according to interviews, they found this type of insurance to be too risky and expensive and have left the markets usually within 2 years of starting up. Australia is very different again, and it uses a number of insurance companies. This has also led to some questionable dealings on whether migrants have had real insurance policies, as some migrants that I work with have been denied treatment in the past for not having the correct documentation. With insurance companies, services are also exclusionary and dependent on the length in the receiving country, and there is also a lack of gendered data. So from my experience in the RSE, employers actively encourage their workers to use their insurance whenever applicable. And this was noted by the insurance company who pleaded with employers at the RSE conference to not encourage migrants to seek insurance, especially in terms of what is deemed as a pre-existing condition. Now, the pre-existing conditions are problematic, and many employers and myself have argued in the past that those pre-existing conditions could have actually been from a previous season of working on a farm, and that they should be considered. So there are concerns about pre-existing conditions. Next slide, please. As mentioned in the opening slide by an employer, they did not comprehend the level of healthcare that would be required for these schemes in New Zealand, and I would also hope in Australia, because we've had many discussions with state government stakeholders about this over the years. There have been a number of initiatives to assist seasonal workers, and directly and indirectly their families and communities back in the Pacific. So they've been organised by governments, healthcare providers, host Australian and New Zealand communities, and even local employers who have funded health initiatives, such as funding towards medical centres and supplies in the Pacific. Many partnerships such as these go under the radar, but are actively assisting workers and their communities back home in the areas of healthcare. And when you think about this, it makes sense in the long term, because assisting and promoting good health in areas that employers wish to continue recruiting from is a strategic investment in the future. And just two examples of government initiatives in New Zealand is the Hawke's Bay District Health was a specific toolkit designed for RSE workers, and it targeted the health issues that we were seeing at the time with RSE workers. And also in New Zealand, the Vakamiasina training programs, which offered first aid training, health and wellness, and worker rights sessions. Both RSE and SWP do provide guidebooks for migrants and have a section on healthcare advice. Though these sections are very limited, they may need to discuss how to eat well, to have good hygiene, to stay in contact with family. And in the case of RSE, but not Australia, there is a section also on sexual health. Next slide, please. So Dr. Charlotte Bedford and I conducted a study on the healthcare management of seasonal workers during COVID-19 for Australia and New Zealand. Now, given the bilateral agreements that Australia and New Zealand have with their Pacific and Timor-Leste counterparts, we argued that, you know, there was an obligation for Australia and New Zealand to look after these migrants during COVID. We saw a number of challenges during COVID, like many other countries did. We had increased mental health concerns. We had exhaustion, fatigue, more injuries occurring because they were exhausted. We had a number of pregnancies occurring within both schemes. And of course, prior to COVID, you know, when the borders were open, it was never a problem that employers or Australian and New Zealand governments had to deal with. When there was a medical issue or if a worker was pregnant, they would just, and I hate to be not so polite on this, they would just send them away and say, next worker, please. And they would be easily replaced, not another thought. But because of the border closures, the Australian and New Zealand employers and governments had to now start dealing with workers and then the limitations of health insurances, especially when we had workers that were diagnosed with cancer and other treatments that were not usually covered. Additionally, I'd also like to argue that the incidences would have been underreported given the limited access and travel restrictions. Next slide, please.
2 minutes, Rochelle.
Thank you. So in terms of COVID, new investments in worker support did happen during the pandemic. We had no reported cases of COVID until the Omicron wave. And then there were concerns on how migrants with COVID were managed. Simon said to me, as one of my workers said, you know, what if they say I have this thing? I'm going to ruin it for everyone. We'll all get shut down. It'll be all my fault. So there was a real sense of shame and a bit of a fear for me that workers wouldn't report that they had COVID because of this fear. Since the pandemic, there has also been increased involvement in financial resources provided for worker wellbeing, but how that translates to healthcare access is still unknown. Next slide, please. Although it's been shown that most migrants in these schemes average between 3 to 5 years, many of my research cohort have been participating every year for 16 years. So we're seeing a lot of occupational overuse, years of repetitive and strenuous labour on their body. Accommodating an ageing workforce has been a consideration of governments and insurance companies, and in fact, Orbit has extended an extended policy that caters for that, covering a wide range that goes much further than the basic insurance. It also covers cancer and also surgeries. Next slide, please. The importance of health doesn't just extend to migrants, but also their families and communities. There have been opportunities, you know, with extra finances, families have been able to increase health service access. However, we're also seeing challenges with physical and mental health concerns when there is an absent household member, and more work needs to get done on how this impacts the health of those in the Pacific when they have a missing household member. Next, please. Next slide. Thank you. So some of my recommendations over the years have been to increase investments into migrant rights and awareness in healthcare access, understanding migrant health prior to departure and on return, improvements to worker health and safety at work and also within the accommodation settings, broadening the scope of basic insurance offerings because it was problematic during COVID as insurances were linked to employer status and visa status, improved data collection to inform research and policymakers, and a consideration of the long-term ageing workforce, their medical requirements and potential compensation plans. Thank you.
Thanks very much, Rochelle. I think it's fascinating to hear about management of the ageing workforce. That's not something we've really addressed on these webinars before. Please, members of the audience, continue to post your questions, and we will move on to our next presentation. We will be also addressing the issue of COVID for migrant workers in the discussion by Dr. Kwan from Singapore. But first, we're going to the Philippines with Mr. Antonio Danao, who's the segment head for migrant workers and overseas Filipinos program for the Philippines Health Insurance Corporation. I'm really looking forward to this. I hand over to you now, Mr. Danao.
Hello, can you hear me?
Great.
Yeah, I think there's a problem with my camera. Yeah, okay. Um, can you see me? No?
No, but that's okay. Let's just
Okay.
keep going.
Yeah, okay. Good afternoon from the Philippines, and thank you for inviting the Philippine Health Insurance Corporation to present our program for our Filipino migrant workers and their families. Next, please. Philippines, we have an estimated 109, I think it's 110 million population. And the or work the 10% are in, so being recorded. And next, please. Okay, so the Philippines in migration at glance, 10.2 million Filipinos are living outside the Philippines. 4.8 million are permanent migrants, maybe somewhere in the US, Australia, and Canada. And 4.2 millions are temporary migrants, meaning the contract workers. And then 1.2 million are considered as irregular migrants. Maybe these people leave the Philippines as a contracted worker, but later on decided to stay in the host country where they are, and they are now undocumented. And we are scattered in 200 destination countries and territories. So it's a big challenge for the Philippine government to ensure that these Filipino citizens can be covered by our health insurance system or the social protection. Next. So at first, what are the National Health Insurance Program? Actually, the National Health Insurance Program is the program of the Philippine government to ensure that Filipinos are covered by the socialized health insurance. And then, so we have the National Health Insurance Program, and then the Philippine Health Insurance Program, or PhilHealth, is the one tasked to manage the Philippine National, the National Health Insurance Program, or the NHIP. And this program, the NSIP, anchored on the social solidarity or bayanihan in Filipino language, meaning those who can help should help. Those people who are well should have to help those people who are sick. So that's the social the national insurance program anchored on the principle of social solidarity. The health of uh, one person in a community is a responsibility of the whole community. So it's a shared responsibility to everyone in the community. Next, please. And how this national health insurance program started. This was started since August 1969. We have a series of changes of the law that governs the implementation of the socialized health insurance, because the program started for the government and private employees only until on November 2019. Fortunately, it is before the pandemic. We passed the law regarding the universal healthcare law that uh, mandating all Filipinos shall be automatically included under the National Health Insurance Program and entitled to immediate eligibility to PhilHealth benefits. So I think that's the fortunate for us. We are some prepare some for the pandemic, and we ensure that all Filipinos are covered by this program. Next, please. So under the Universal Healthcare Act, the Filipino populations is divided into two categories: the direct contributors and the indirect contributors. The direct contributors are those people who have the capacity to pay, who are gainfully employed and are bound by employer-employee uh, employer-employee relationship, those who are self-earning, professional practitioners, and this include the migrant workers, including their qualified dependents and the lifetime members. On the other side, the indirect contributors are those people who are not included on the indirect contributors. Contributions are being provided by the or being subsidized by the national um, governments. Those include those person with disability, senior citizen, and others in the other sectors not qualified under the direct contributors. Next, please. Okay, so I have this is the category of our society under the its type of the membership category, like what I have explained before, the direct contributor and the indirect contributors, because the law says that all Filipinos should be covered by the National Insurance Program. So we have to categorize all member of the Philippine society in whatever membership category. So those who have the capability to help should help, and those people who needs help should be provided help from the government. And also, yeah, because the help is coming from a taxes from the members, so it's also the direct contributors who help the other side of the membership category. Next. Next, please. So what are the program? The other side, please. The one before. Let's go back, please. One slide. Yeah, okay. So what, like what I said, the migrant worker are considered as the direct contributor, meaning they are mandatory member, even if they are outside the Philippines. They have the responsibility, and being a Filipino, they should always providing support to those people who are being supported by the national government. But this program for the overseas Filipinos is not new. We have this program since 1994 because, like I've said, 10% of Filipinos for now is working and living outside the Philippines. We should ensure that those people who will be working outside the Philippines should be covered by the health insurance, especially those overseas contract workers. And because even if they have their social protection in the host country, the problem is what will happen to their family who will be in the Philippines, who will pay for their contributions, who will pay for the coverage in the health insurance. Okay, and next, please. So this is the other side is I just put this this slide just to announce the benefits for our COVID-19 package in preparation. I think 2 years before, we are not prepared for the COVID-19, but we have ensured that even if we are not prepared, we have to offer something for our members, especially those coming home because of some layoffs, or they don't have work, so they have to go home. So, but we have to prepare, we have to test them to ensure that we have also to protect Filipinos here in the Philippines. And as member of the as member of the overseas, can we go back, please? The previous slide. Thank you. This is the overseas Filipinos program. It is program for the Filipinos outside the Philippines, not only the worker but all Filipinos living, provided that they are not yet a citizen of the host country where they are working or where they are living. They are still considered as Filipinos, so they are entitled of these uh, privileges. Automatic availment, or what we call is the immediate eligibility, is that before in our insurance policy, you should have a premium contribution before we can use or before you can avail the benefits. But under the new law, even if your contribution is not complete, but you are on the hospital, you are in the emergency, you can avail the benefits on the condition that when you uh, go out in the hospital and you can earn again, you have to pay those contribution that you the lacking contribution and in your premium contribution. For the migrant workers, we call it portable. Even we do not have yet an accredited health facility abroad. But what we do is that even if the hospitalization has been done overseas, we still pay on that hospitalization. But we have to pay them on how much on how much we pay if that hospitalization will be done in the Philippines. For example, a cesarean operation, if we pay 16,000 pesos in the Philippines, even if you are being hospitalized abroad, we are going to pay them 16,000 pesos. At least they can have reimbursed some of the expenses that have been incurred due to that hospitalization. Um, yeah, portable benefits wherever wherever they go, they can avail the benefits, but they have to pay it first, and then they have to reimburse it here in the Philippines. They have 6 months to file for the reimbursement, and then we have to pay them the what is the benefits that should be given to them. And then another um, features of the National Health Insurance Program. Actually, it's not only for the migrant workers, but to all Filipino members, that our coverage is the whole family. What you, one principal members will be paying for the whole family. And who are this family? Yeah, the principal member, meaning the migrant workers. Second, the immediate, I mean the legal spouse, the legal husband, and then all those minor children, 20 years old below, and parents above 60 years old. So one payment, it's cover all the member of the family. And the benefits is a unified benefits for all members. Benefits are not dependent on how much you pay, but it's defined on what are the reason why you are hospitalized. The benefits that being received by the principal member is equal also to the one being received by the dependents, and also to those other member of the National Health Insurance Program who are being subsidized by the government. So the benefits is um, unified benefits. So everybody gets what belong to them. Okay. Next, please. Yeah, but we have this challenge brought by the COVID-19, and then we have this some local challenge in the policy. We have this the mandatory premium payment for PhilHealth has been removed on the overseas certificate. So we have to look for other options so that we can require at least the initial payment for the first year, because it's very difficult for us to locate those Filipinos outside the Philippines and ask them to pay for the next years. So we have to require them that to pay just maybe the initial 1 year to ensure that they are covered on the initial year, and then COVID-19 come, and they have almost half of the overseas Filipino workers are being repatriated back to the Philippines. So we have to prepare, especially the mandatory testing, all those repatriated back to the Philippines. And then another one is we have these issues in 2020 that payment for the migrant workers is mandatory, but we are now working it again to make it a requirements for all of them, just to ensure that the program will be sustainable, especially that we have this provision that immediate eligibility, even if you have incomplete payment, you can avail the benefits. So it's a big challenge for us, but we have to do it as a country. We have to cover them to ensure that all of us can avail of these benefits. Next. So we have this established way on how to convince them, to encourage them to continuously pay the premium even if they are outside the Philippines. So we have this account management for all members. We have this statement to premium account to ensure to send them the billing on how much they have to pay for this coming months. And then we have also expansion of existing collecting and payment windows, payment using the bank, the ATMs, the credit cards, and also all those payment windows that we can think of, that to ensure that payment option is available under where they are. And then we have also this partnership with the local government units for the assessment of those people who are financially incapable, and also to encourage the family. If the OFW will not pay the contribution, maybe we encourage the family who are live here in the Philippines to encourage the member to pay the contribution for them, because the coverage is not only for the member but for the whole family. And the last one is that we have this plan of setting up of, actually we have this plan 5 years ago, the setting up of PhilHealth representative office at PhilHealth post abroad, so that we can continue the marketing, the updating of the contribution. But because of the COVID-19, we stopped the plan, and then in this year, maybe by next year 2024, we can continue the plan of setting up for those countries that we have a lot of overseas Filipinos, especially in the Gulf areas, in the GCC areas, where almost half of Filipinos are working, and almost 2 million or 3 million are half of that is women. They are working as household help. So some of them are in the they are not covered by the insurance provided by the host country, because household some countries did not consider the household help as worker. So they are not covered by some are not covered by the mandatory health insurance provided by the employer. Okay, so next. Thank you very much from the Philippines. Thank you.
Thank you very much, Antonio. I take from that statement that the health of one person is the responsibility of all persons in the community. It's a beautiful philosophy. Next to speak to us is Dr. Benjamin Kwan from Singapore, and he's the CEO of HealthServe Limited. He's going to talk to us on social health protection for migrant workers during and post-COVID-19 pandemic. Thank you, Dr. Kwan, and the floor is yours.
All right. Thank you so much, Christine. And thank you all for inviting me to this forum. Can you all hear me?
Yes.
Yes. All right. So it's great to hear from the other speakers about how the different initiatives in Laos, Philippines, and Australia, and the various, universal healthcare arrangements available. I think Singapore is very small in comparison. Some of our successes in the pandemic response is due to us having a small territory. But at the same time, we have a very dense living conditions for both residents and migrant workers. This contributed to some of the challenges precisely we encountered during COVID. All right, but overall, overall, Singapore does have some degree of it does have mandatory medical insurance for migrant workers, both male and female, even before the pandemic. All right, just in case you go away thinking that there are a lot of things that were not present, but there were gaps that were tightened across the pandemic. All right. So a bit about myself. I'm a family physician by training. I got an MBA, worked in a managed healthcare organization for over 10 years before joining HealthServe, which is a charity 3 years ago, just at the start of the pandemic. So HealthServe, we are a registered charity with the government. We are the only medical charity in Singapore that provides holistic healthcare to the migrant workers. All right. Of course, most of our focus is on male migrant workers, but we are, of course, not saying that we don't care for the females. All right. So services that we do provide are as shown on the slides. We do have our medical and dental services, mental health and counseling, as well as casework and social support services. We've been around almost 17 years, right? And across the pandemic, we were very involved with the government ministries and various stakeholders in providing a whole of government, whole of nation response, right? And in a sense, the social health protection for the migrant workers, right? So yeah, maybe we go to the next slide, right? So just to put things in a bit of context, right? Singapore, we have about close to 6 million people on the island, right, including migrant workers. There's only about there's about 1 million of the workers who are in the so-called more lower wage sector, of which about 415,000 are in the construction, marine, shipyard, and process sectors. These are also traditionally the lowest wage workers, many of them coming from South Asia and a smattering of the East Asian countries. We also have almost 270,000 migrant domestic helpers, and that's data from December last year officially. All right. Next slide. Just for comparison, in June 2020, that was just at the start of the pandemic, right? We had just about 330,000 of the CMP workers. So part of the increase is because Singapore is trying to do catch-up growth, right? And likewise with the foreign domestic helpers, there's also the increase, right? Just putting some things in context, comparison, right? Next slide. Right, so some of these perspectives for many of us here who have worked with migrant workers or displaced communities, know that there are various vulnerabilities. For a migrant worker to come to Singapore, typically have to pay something like 6,000 to 10,000 Singapore dollars. That translates about 5,000 to 8,000 US. All right, in terms of agent fees. So difficult work conditions, and their daily wages comes up to just about probably around $20 per day, 20-25, including overtime. So if they have to fork out about 8,000 Singapore dollars, and they have a monthly wage of 600 to 800 Singapore dollars, you can imagine how vulnerable they are and how challenging they are in terms of their bargaining power, right, with their employers. Right. Next slide. Right. So there's unequal power dynamics. All right. And again, I think it's not unique to Singapore. It's just putting things in perspective in dollar sense, right? A worker typically gets a 2 years contract to work in Singapore, and they fear losing their work. So there's always that pressure there to do well. All right. Okay. Next. Right. So these are just some of the determinants of health that makes it a bit challenging for the workers. All right. We can go to the next slide. So I'm going to share a bit about how Singapore responded, all right? But as a quick overview, all right, the pandemic, you will have read probably in the word press that it affected the male migrant workers disproportionately, all right, especially because majority of them lived in dense dormitory situations. By around April or May 2020, majority of the newly diagnosed COVID-19 cases came from the migrant workers dormitories, right? Of course, the female domestic workers and other sectors of migrant workers were, of course, affected by the pandemic, but nowhere as so as the dormitory staying migrant workers. But thankfully, we have overall single-digit fatalities to date with respect to the migrant workers succumbing to COVID, right? Okay, next slide. So, well, I'm going to share also about more details about government measures that stepped in to help with the workers. This is just a quick overview slide. Next slide. Also, both in terms of the response during the pandemic as well as when we transition to the post-pandemic situation. Next slide. Of course, to note, many NGOs stepped in to work alongside the government and the employers, the various stakeholders to take care of the migrant workers in terms of the social health protection. Just putting out a list of the more prominent NGOs. One of them, of course, is My Brother SG. Some of you may be familiar with. They are actually part of the WHO RCCE framework partner based in Singapore. All right. Okay. Next slide. Let's talk about how we responded to the pandemic at the start. Okay, next. So I already mentioned how migrant workers were differentially affected, especially those who are living in the dorms. These are just some press articles that you can still find out there. I think from a public health perspective, most of us are aware that it's due to the lack of dense living conditions, and there is really a lack of space to decongest or decant them. Right. So people will have no choice but living close together. So the decision will then be to manage the infections in situ without decanting them to care facilities, or at least not so many of them. All right. But because of that, there were prolonged lockdowns, right, for the migrant workers. Right. For the general Singapore public, there was a circuit breaker or general lockdown of close to 7 weeks. But for the migrant workers, it probably started from April, ran all the way to June and July. That was a good 2-3 months. And because they couldn't send money back home, right, they were in a lot of distress. And moreover, as the pandemic evolved in Asia, back in South Asia, it was just starting to brew out. And their family members started succumbing to the pandemic as the months wore on. Next slide. Right. So some of the focus group feedback we had from the dormitory residents, well, you can see here, things like cabin fever, substance use, and all this. Well, Health served as a medical charity. Our social workers, case workers, or even the medical team myself, we went down to dormitories to engage with the migrant workers to see where their challenges are. What are the issues? And of course, we give the feedback to the medical teams on the ground. We fed back to the government ministries, and we try to work together to see how best to, address the issues of the workers. I mean, some of the issues that we shared was like, for example, the South Asian workers, they are staying in a dorm with a room of 10 to 12 individuals. Public health policy mandates that we should stick to our own space, eat from our own bento boxes, pack food, you don't share. But for the South Asians, they love to be communal. In fact, when they're given the bento boxes during quarantine, they'll sit down on the floor, put all the food in a nice big pile on the ground, and started eating with their hands. And to the dismay and shock of the government healthcare workers, right? So we came in and we shared that, look, honestly, if they're all going to be in the room for the next 1-2 months, if they're going to get infected, there's not much you can do, all right? You might as well let them enjoy a bit of this communal, engagement, right? So this was just one of those things that we helped to give feedback on, right? Yeah, we also shared about some of the things they can do, like, they like to play caroms, all right? Some board games and all this. Again, if they're in their rooms, there's no point in trying to keep them absolutely separate, all right? So yeah, So next slide. So the plan, after a while, because of the surging number of cases, right, the whole of the nation decided that there's no way we could transfer hundreds of thousands of workers to the hospitals or even to care facilities, right? So all the mild cases we tried to manage within the dormitories itself, right? So the dormitories are all locked down, right? Workers were not allowed to move in and out, right? Well, kudos to the government, especially the military. They sent in their medical teams as a first response team to the large dormitories. So for context, there are about 50 large dormitories across Singapore. At the start of the pandemic, they housed close to 200,000 workers. So you can imagine a typical dormitory will have 5,000 to 8,000 workers. If they cannot move about and they're starting to come down with COVID symptoms, you need to have a medical team on site. So that's where the military teams first went in. All right. After that, the government hospital teams were deployed in. Then there was the call for the private sector to step in. Then as we move on to later through the pandemic, there was that transition to the more sustainable healthcare system. But for a start, what the government did was it provided free medical care, all right, to all the migrant workers in the dormitory, all right. So things like whether it's acute care, chronic care, all right, the medical teams just provided the treatment. If we were to be transferred to the hospital for COVID-related stuff, it was also cared for by the state, all right. Okay, next slide. So besides, the quarantine and lockdowns of the dorms, all right, again, I mentioned migrant workers, all right, who were taken to the hospitals for treatment. The healthcare team spared no effort. They basically did not treat them any differently, all right. You can see here, this is a story of one of the first migrant brothers infected with COVID, who came down quite badly and had to end up in the ICU, but he survived it, all right. We also set up, quarantine facilities, right, for all Singaporeans as well as for the migrant workers. You can see here, all right, you've got a cruise ship being set up for the migrant workers quarantine, all right. Yeah, and then you can see that some of the healthcare workers also at the care facilities teaching them some dance routines and all that, right? So while it was a lockdown situation, everyone did their best and to also engage the workers, right, keep them cheerful and all that. And of course, the government pumped in financial assistance to companies to prevent them from going bankrupt, right? So this will in turn, mitigate subsequent downstream, fallout affecting the workers. All right. So you have medical coverage, you have financial assistance from the government coming in. Next. So because of the dense living conditions, everyone quickly realized that we have to start thinking about how to, house the migrant workers better moving ahead. So of course, during the pandemic, there's not too much that we can do, but all the same, the government managed to identify some sites where you could develop a few quick built dormitories, where each dormitory can house anywhere from like 2,000 to 5,000 workers. So there was some design consultation with all the stakeholders, public health experts, all right, architects, dorm operators. I think some of them are in the audience today, all right. And then, of course, new dormitories with lower density was quickly introduced, all right. So you can see in the picture, some of the conceptual ones, we have 8 people in a room, all right. Some are even lower density, 5 workers to 1 room compared to the traditional 10 to 20. And instead of a communal bathroom of 20 toilets, bathroom units, you have ensuite toilets. This is so that you enclose, if there are infectious clusters, you can lock them down, you can contain them much better. All right. Okay, so next. So throughout all this, the NGOs stepped up and to plug the gaps. Of course, besides the NGOs doing their own thing, the government was also quite quick to form collectives to bring everyone together to share the knowledge. Because really, at the early part of the pandemic, when dormitories were locked down, employers stopped work, a lot of workers were left without food, especially in the smaller residences. So you can see some of the NGOs giving out food aid early on. Many stepped up to provide befriending and telecounseling helplines. HealthServe, of course, was one of them. We stepped up with our counselors and we worked with the government in one of the task force. Right, come next. As things evolved, as the pandemic evolved, things also started to stabilize. We figured out how to transfer workers to care facilities, and thankfully most of the cases were mild, right? But there was the mental health burden on workers, and suicides were on the rise. So the government started a task force between NGOs, mental health practitioners, to address the mental health needs, right? This is where HealthServe stepped up together with the government to, work on the 24/7 suicide helpline. And we also have an escalation pathway to refer workers where we detect during telecounseling, right, to the hospitals, psychiatric hospitals, right? Next.
2 minutes, Benjamin.
All right. Okay. So next. So as we progress, we have to reopen the society, right? Next. This is when the vaccination started coming in, ART test kits, PCR swabs were getting more common, right? The next phase of our response came in. So in order for society to open, you want the workers to go back to work, we decided to do fortnightly PCR swabs on the workers. So if you are negative, right, you are safe to go back into the community. But as a surveillance, regular surveillance, every 2 weeks, the workers will be swabbed. All these are paid for by the state, right, and not at the cost of their employers, right? Then a few months later, when the vaccine finally became available, the vaccines were also rolled out to the migrant workers, all right? So there was a very high take-up rate for the migrant workers, in fact. At one point in time, it was at a higher take-up than even the general public, right? At close to 97, 98% compared to the public, which, of course, because of the big age range, but for all those who are eligible, right, even then, there were a lot more vaccine hesitancy, right? Yeah. So the workers were taken care of by the government with vaccines equally available to them, right, so that they can go back to work safely, right? Next. Right. So yes, as I mentioned, while there were very high infection rates, thankfully death rates were very low, all right? In fact, although it's not openly published, the number of deaths directly attributable to COVID-19 in the male CMP migrant worker circle is less than 5, if I don't remember wrong, right? Even to date, right? So we were very fortunate, right? Partially because maybe the way the virus was, maybe because of the quick response that everyone stepped in, and also the various mitigating steps, vaccines that came in that helped with the entire outcome of the pandemic. Next. Right. So remember I was talking about how suicides, mental health was a big issue, right? This is a part where HealthServe, again, together with the Mental Health Task Force, we stepped up to, provide mental health awareness talks, sharings. We also train peer ambassadors, right? We call it peer support leaders from the community. I think this is a well-acknowledged model in many other countries, right? So over here, we are teaching them psychological first aid so that they could at least help identify peers or colleagues who may be a bit more distressed, right? Because they speak their own native languages, and then direct them for further help, whether it's with HealthServe or other helplines. So HealthServe, we started a 24/7 suicide helpline manned by speakers of their languages. So namely Tamil and Bengali, right? Because these are the two largest migrant worker groups in the construction sector. Of course, there are others like Vietnamese, Chinese and all that. We will have our volunteers who are able to provide callback, or if they're on shift, they can take the calls. So the idea is our helpline is very different from all the other national helplines because our para-counselors immediately can speak their language, right? Which helps a lot, right? Next. Right. So moving to the post-pandemic phase, right? Next. Right. One of the gaps that was identified was lack of a systemic, GP primary care, coverage for the male migrant workers. So even though there was some form of insurance, later I'll share some tables, as you can see. The insurance covered, mandatory insurance covered more the inpatient portion, work injuries and all that, more critical illnesses. But in the primary GP sector, a lot of times it may be left to the employers to pay out of pocket, all right? So during the pandemic, there was a recognition that more needs to be done for surveillance and also for more promptly response. So this is where the government put out a tender for the private sector to step up and provide a steady state medical system for the workers. Next. So Singapore was sort of carved up into 6 different sectors, and we've got different medical providers now since April last year, providing a capitated model kind of primary care. So from previously where employers had to pay out of pocket, or for that matter, Many workers may be asked to pay out of pocket by their employers, right? Remember, their daily wages is about $20 to $30. A typical GP consult in Singapore can cost anywhere from $50 to $80, right? So now with this capitated plan, workers are entitled to unlimited visits, both acute and chronic, and each time they only co-pay $5. So this is a great development. This is a mandatory sort of capitated plan that all new workers have to sign up for. And as of 1st April 2023 this year, all the CMP sector workers have been covered. All right. So that's one of the, in a way, to HealthServe is one of the best silver lining that came out from the storms. There was a pandemic. All right. Next. So beyond the primary care, the government also recognized that there was a need for more inpatient coverage. Keeping in mind, in Singapore, there is no subsidized medical care for migrant workers. Subsidized care, right, only applies to the residents, right? If you have only 15,000 inpatient coverage, it quickly runs out. So as of this year, as of 1st of July, right, this will be raised to 60,000 minimum coverage, right? Of course, some employers will buy more than that, but if you run a big workforce, more than 100,000 workers, a lot of the employers may just go for the bare minimum, right? So the good thing is this new insurance coverage also covers domestic helpers, right? The female workers, right? And there was also the new Improved Dormitory Management Act, which covers the smaller dormitories. Remember, I was mentioning early in the pandemic, the big dorms, we have the medical teams go in, but the smaller dorms, right, that house anywhere from 10 to 100 workers and maybe managed by their own employers, they may be left in the lurch, right? So this is where the government decided to step in to regulate it more, right? To have more oversight. So if there is a next pandemic that comes along, there'll be more, supervision. There will be faster, workflow to close the gaps on various aspects. Next.
Okay, Benjamin, we're at time now.
All right. Okay. So these are just the few slides for those who are interested. Primary care. Okay. Next slide. For the male workers. All right. Next. For the female workers, there's no primary care plan that is mandatory. So we'll be working on this with the domestic helpers in time to come. Next. All right. So to sum, right. I think, again, male migrant workers were disproportionately affected during this pandemic. But the healthcare systems gaps were quickly plugged at no expense, no sparing any expense from the government. NGOs play a big part, but also the employers and stakeholders stepped up. We were fortunate to have very low fatalities, and we've taken all these learnings to be incorporated in the nation's next pandemic defense infrastructure. All right. Thank you so much. All right. We can discuss questions later. All right.
Thank you very much. Fascinating. And now we will turn to some questions of the panel. And the first question I want to ask is of Antonio. This has been raised by one of our people online. And the question here is there any plan or way of addressing climate change or the consequences of climate crisis with extreme temperatures and weather conditions? And therefore, should we be thinking about treatment-related facilities at the work site? Well, Antonio's thinking about that. I'll throw a second question to Rochelle. And Rochelle, this question has been raised about sexual harassment. Now, you did raise the point that mostly this is male workers. Is there any plan or response for sexually harassed Pacific workers in either Australia or New Zealand?
Thanks for the question. Yes, it was a major issue during COVID, especially when they were in dormitories close to each other, male and female quarters. There was a lot of sexual harassment, sexual assault occurring during COVID. The plan has been ad hoc at best, and there are ways to go. Nothing has been resolved as of yet. But, you know, there's also more discussions about, in the paper that Dr. Charlotte Bedford and I are doing that came from our paper, is looking at access to healthcare services, sexual healthcare services and awarenesses and workers' rights amongst that. But we did have issues throughout COVID within regards, and we had it prior to COVID, but it was more obvious during COVID when workers just had nowhere to escape from each other. Yeah. I know that doesn't answer your question, but it's in the government's eyes, but I don't know, especially in Australia with it being such a large continent, how it's being addressed by the Pacific Labour Facility at this stage.
Thank you very much. Now, this question is for Benjamin, and it's on whether there are any undocumented migrant workers, and if so, how do they actually access your services?
Yeah, all right. Thanks for the question. Yeah, I put down the note somewhere earlier on, wanted to mention it, but I've sort of missed it. So Singapore is a very small country, very tightly regulated. Very few undocumented workers, but certainly there are, all right. So, they are very few, all right. So we don't actually have much of a challenge in handling this group of workers. If they need help, frequently they will seek assistance through the NGOs, and if need to, they will cross-refer to provide financial support to seek medical help. Right.
Okay, thanks very much. And then one further question that's been raised is around the issues of migrant workers subject to prolonged mobility restrictions. I think you probably read that in the chat box, compared to the resident population. Now, you're not responsible for government policy, but I'm sure you had to address those questions raised by people about whether there were some differentials applied to migrant workers compared to Singaporean citizens.
Yeah, very good questions. These are things that even if you read the press during the pandemic, it's quite openly discussed. I think to put it simply is that there is a public health perspective, but there is also the political office holders' perspective on what is considered safe pandemic management. So I think certain individuals felt that it was more prudent to manage a bit more conservatively for the migrant workers because of the large number of cases. So there was that prolonged lockdowns. Having said that, practically all the NGOs provided feedback. Many of them are constructive feedback to stress on various ways to engage the workers. And I think that's also partly how, as a workaround, right, what happens is that the NGOs went to the dormitories to engage the workers, running programs and all that. So HELSA wasn't just the only one. That just now the earlier list that I listed out, many of them were involved. Right. If they can't go out, we go there. Yeah.
Okay, thank you. Antonio, we missed with this question before. I'm just going to ask a different question. And this question is about migrant workers in the Philippines. So we've talked about Filipino citizens being covered, but what about migrant workers within the Philippines? How are they actually covered? What's their social health protection state? You're muted.
Thank you.
Thank you.
Those migrant workers who are not covered by the National Health Insurance Program, it depends on why they are in the country. If they are working for a multinational company, so they are considered as employed member, so they are covered by the National Health Insurance Program. We have also this program for retirees through the Philippine Retirement Authority. Those foreign nationals who are going to take the retirement in the Philippines, we have this program also for them through the Philippine Retirement Agency. We are going to pay a much higher premium, but they can avail the same benefits as the Filipino nationals. And then we have also the coverage of those people who are refugee on those who are seeking asylum. We have also a program for them that we are covered by the program. The national government will be going to pay for their premium for the time that they are here in the Philippines. And we have also those workers through the POGO, what's that term? It's the Chinese worker in here in the Philippines. So if they are formally employed, they are covered. But if they are informal category, for now we don't have a program for them.
Okay, thank you very much. I've got one more question, and that question goes to you, Rochelle. And the question is addresses the role of the local union movements. Are they useful in supporting Pacific workers who may have had their rights impeded? You're muted.
I got a really simple answer for that: yes and no. They can also overcomplicate things, and workers, if it actually, to be honest, workers have felt bullied by unions reps, so that causes more problems. But they can be useful. I think I think there is definitely a place for unions in these schemes, but I think there needs to also be a governing body watching what the unions are doing and the advice that they're giving in these worker programs. But I definitely think there's a place. However, like I said, there's been complications with unions in the past. So yeah, I'm for them, and I'm not always against them.
All right. Thank you very much. And I'd like to thank all the panelists for their presentations and also for responding so openly to all of these questions. I'm sorry that we can't answer all the questions in the time that we've got. I'm very grateful for you all listening. We would like to invite you to answer a survey which addresses your own, there it is, addresses your own experiences and interests in social health protection, and we're going to put it in the chat box, and I think we've posted it out for those people who already enrolled in this. Our next webinar will be in another month, and that webinar will be addressing the experiences of people in Latin America and Africa. So they will be, that's a reflection, they will be reflecting on these experiences that we've also learned in Asia and the Pacific. I would like to thank all of you, all of our panelists, and all of you too for listening, and I look forward to seeing you again in a month. Thank you very much.